Hi, everyone. Welcome to this PCR webinar about overcoming the challenges in the lifetime management of young TAVI patients. That is definitely a burning issue and a contemporary concern. So my name is Didier Cheche. I'm from France, and I have the great privilege to work with a very nice team of friends. And I'm quite happy to see that we are all coming from different part of the globe, different countries, and this is going to bring a broader perspective to this very important topic. So this is a PCR style webinar that is case-based. So we're going to see two very interesting cases that are going to stimulate the discussion. But I would like to start by introducing the team today. So Danny Advir from Israel is going to co-moderate the session with myself. So hi, Danny.
Hello, good to be with you.
Sabine Bleitifer from Germany is also going to provide more input from a hybrid operator, both from the surgical and the transcatheter field. So hi, Sabine. And last but not least, Deepak Taljera from the US, that is going to bring perspective from someone who was potentially treated more younger and lower risk patients, given the indications in the United States. So having said that, today, what we can expect from the webinar is to discuss, as I said, two very interesting cases, and we will try to address the issues of the criteria for the valve choice and the first procedure in a younger patient with a longer life expectancy. We will try to apprehend the durability with the contemporary TAVI platforms that we are using today, and at last to try to understand the potential impact of specific anatomies on valve performance. So this is a quite dense menu and agenda, but maybe, Danny, we can talk a little bit more about what we expect in terms of interactivity today.
Absolutely. So I invite all the listeners to join us in the discussion. We have very interesting and important cases that we see on a daily basis, and we want you to take part and ask questions. We will try the most we can to accommodate your questions and answer them.
Perfect. So maybe we can move to the first case, and I guess then it's going to be Sabine, if I'm right.
So hello again from my side. I'm really glad to join this webinar. Thanks for the invitation. And I'm happy to share with you one case of a female patient we treated just last month. So this is a 66-year-old female patient. She was somewhat obese with 168 centimeters and 92 kilograms. And indeed, she was really symptomatic. So to me, this was really amazing that nobody has thought of a cardiac disease before. She had a dyspnea on exertion. She had retrosternal tightness, some dizziness, some edema occasionally. And she suffered from these symptoms for more than 1 year so far. She had no syncopes. She is living independently. She has a smoking history with 30 pack years and also a significant family history. So December last year, she was admitted to the hospital for a cardiac decompensation, and still nobody thought first about a cardiac cause of that. She had a suspected deep vein thrombosis, but this was not confirmed finally, and her diagnosis then was severe aortic valve stenosis indeed, and I will show you the echo later. She also had a good left ventricular function, no coronary artery disease, some significant cardiovascular risk factors, and also severe COPD and some other comorbidities. Looking at her echo, there was severe aortic valve stenosis confirmed with a mean gradient above 40 millimeters mercury and with a good left ventricular function. Her coronary angiogram was demonstrated no coronary artery disease. And then a CT was done, showing a tricuspid aortic valve with not so heavy calcifications, which is typical for the female aortic stenosis. She did have some or one spot of calcium in the LVOT, which is not too big. She has a small anatomy with an annulus of 21.3, perimeter 68, area 355 square millimeters. The sinuses were quite narrow, but not too narrow. Normal coronary takeoff height and normal peripheral arteries. So good transfemoral anatomy. So we now had to take the decision for this patient, and we had a pulmonological statement of her COPD showing an FEV1 of less than 50%. And so the pulmonological colleague told us this would be really an increased risk if this patient is ventilated. And on the other hand, we have a quite low risk TAVI anatomy with a good peripheral access, tricuspid valve, no severe calcifications except for one small calcium spot. So, weighing these factors, we decided for this patient to go for a TAVI without intubation, of course. We did a pre-dilatation to prepare this calcium spot. We implanted an Evolut FX 26 millimeter valve, and we can discuss later about valve choice. You see now the cusp overlap angulation, where you see that we did a very good alignment of this valve. So the small spots or dots there show the commissures of the prosthetic valve. And after the implantation, we did a post-dilatation because we still saw some PVL on echo, and the valve did not appear completely deployed. And when you look at the final result, you see there is only really a very tiny residual paravalvular leak. And from the femoral side, everything was okay. So the patient then went to the normal ward, which is a standard procedure at my center. She had an echo prior to discharge, which demonstrated single-digit mean gradient, which is a perfect result, I would say. Minimal paravalvular leakage, which is certainly due to this calcium spot in the LVOT. And she was indeed discharged on day 2 because she's young and she had a quite quick recovery from this procedure without intubation and without general anesthesia. So this was my case, and I'm happy to discuss our decisions with you.
Thank you very much, Sabine. So I will hand over to you, Danny, to kick off the discussion. But once again, just to remind you guys that are connected online that you have the ability to pop up your comments through the chat. And I have a close look on the chat, so we should be happy to answer your comments. So please, Danny.
Thank you, Didier. So Sabine, a very interesting case, a 66-year-old lady with severe aortic stenosis.
You asked me about how often we do treat younger patients at my center or in Germany, and I have to say that this is not quite common. I would say it's less than 5% of patients at the age of lower than 65 years, and it is only if there is an increased surgical risk. So we still have our European guidelines. We are expecting new guidelines this year. We will see if there will be something new on the age cutoff, but for now, I would say it's quite rare that we have so very young patients. The main reasons why risk is so high is for pulmonary disease, as in this patient, and some cancer patients, or if the anatomy for TAVI is really, really bad.
So it's true. I don't know if it's the same for you, Danny, but for instance, in France and Germany, it's exactly what Sabine has mentioned. And these very young patients have comorbidities. So they are young, potentially with an adequate life expectancy, close to 15, between 15 and sometimes 20 years. But they have comorbidities, and this is the main reason, high surgery, at least intermediate to high surgical risk. So maybe I could ask you, Deepak, about the US experience, because you are potentially, we think, from our side of the globe, that you are treating more younger patients. What is it? What is the reality there?
I think that is true. I think, again, we try to always individualize to each patient what the treatment is, recognizing that surgery is an absolutely fantastic treatment for aortic valve replacement. That being said, there's a disconnect between the European and the U.S. guidelines. The Journal of the American College of Cardiology and American Heart Association tend to set the age at 65. And while it's a minority of patients, we do lower than that. Now, in the era of considering lifetime management, we recognize a lot of those patients will need more than one aortic procedure. And so sometimes we take into account patient preference, deciding, do we maybe do TAVR, then SAVR, then TAVR, and so on? Or do we start with SAVR and TAVR next? And in an anatomy that would be open to both positions, we probably do more cases at a younger age than in Europe.
Okay, thank you very much for this perspective. So you are back with us, Danny. So you were asking Sabine about the choice between the reason for performing TAVI in the younger patients. So I hand back to you for leading the discussion. Thank you.
Is it a common consideration for you, Sabine, to look at the anatomy of a patient and then decide whether to go to surgery versus to go to transcatheter approach? Like to say, if this is a small anatomy, I would choose to do TAVI with a supraannular device in order to maximize hemodynamics later on.
So there are many things we could discuss about that. So because with surgery, indeed, in small anatomies, you have even more options with annular enlargement. If this is done, we know this is not done very frequently. It's done in about 5% of all surgical aortic valve replacement procedures. But in theory, this is a very good option to implant a larger valve for a longer lifetime management with several procedures. When deciding for TAVI, of course, in a small anatomy, we always prefer to go for a supraannular valve. From the SMART trial, we know there are better hemodynamics with lower gradients, and this could be confirmed in the patient case I just showed, because we were able to achieve a single-digit gradient in this patient, and I think this was one of the main decision makings in this case for us, to give the patient the opportunity to recover from all that symptoms, because she has also more than one reason for dyspnea. It's also her COPD, of course.
Thank you. So I guess this case is quite illustrative of the more recent data. And as you said, we had the SMART data published last year, 2 years data presented at the ACC. So we are understanding more about the impact of TAVI, the potential advantage of TAVI, and differences in between platforms in small aortic annuli, and particularly in female patients. So we understand the choice of the device for your patient, but I have a very frank question to you, because if we decide to go for TAVI in a younger patient, some operator may have different behaviors. So the question for you, and maybe I would like to start with you, Danny. The question is, do you think that the self-expanding supraannular platform like the Evolut FX is suited as the first device for a younger patient with a longer life expectancy? And why?
Well, when we talk about TAVI in younger patients, there are many things that we want for the long run. We want their valves to function the best we can, right? We treat patients with severe aortic stenosis. This is a hemodynamic pathology. We have elevated gradients at baseline. We want to eliminate as much as we can these gradients. We want them not to have paravalvular leakage. We want them to feel well, especially when they exert themselves, because this is the time when they need the most cardiac output they can. We want them not to have conduction defects. We want these valves to last as much as we can for many years, hopefully more than 15 years if we can. If they fail, we want them to be treated easily with another valve. If they need PCI, which is not a common scenario, but it can happen, we want them to have that PCI more easily. I think more and more that if the hemodynamics with supraannular devices are superb, and actually they are so good, we see in the SMART study single-digit numbers for patients with small annuli, mean gradient of 8 on average, and aortic valve area, like Sabine's case, around 2 centimeters square, sometimes even more, and durability that we see from long-term studies like Notion to be so superb. So durability and hemodynamics are so good, then I feel very comfortable to offer it for younger people. With the challenge of doing TAV in TAV later on, we know that in the majority of cases, it wouldn't be a problem to put another valve inside. If that would be an issue later on, I assume that in a couple of years, we will have so many tools to enable easier TAV in TAV that I don't see that as a challenge anymore.
Do you share the same perspective, Deepak?
I do. And I think Danny said it so eloquently. I don't have a lot to add, but what I would say is I think in this era where we're thinking so carefully about lifetime management, doing everything we can to get the first best result becomes critical regardless of age, more so obviously in young people, but even in older patients. And that's where I think those hemodynamics make a huge difference. And as Danny very eloquently said, I think this is a very reasonable platform given that we don't see, especially with the FX Plus, the large coronary windows are very easy to cannulate. Pacemaker risk is low with what we learned from Optimize Pro and high implant. So assuming reasonable coronary heights and sinus spaces, we would defer to this as the first kind of choice.
And I have to say that I definitely share the same idea, the same thoughts, and I don't see any reason why to use the self-expanding supraannular platform in a younger patient, lower risk, given the fact that we're going to discuss that afterwards, but the durability is superb, and we have data that support 10 years durability and comparable outcomes when compared to surgery with this type of platform that has remained the same from the very first days to today. It's the same platform, the same structure. So this is quite reassuring, I have to say. And Danny, you mentioned the redo procedure aspect. Deepak, you're going to deep dive into that afterwards. So we will have time to discuss this aspect. But Sabine, a question for you is, we have different iterations, and not everywhere in the globe or even in Europe we are using the same structure in terms of stent frame. It's the same leaflet design, the same leaflet location for the Evolut platform, but you chose the Evolut FX Plus. So would you tell the audience, for those who are not familiar with that platform, what are the novelties about that?
So the Evolut FX added those visible dots beneath the commissures of the prosthesis. So you can do commissural alignment visibly during the procedure, which is important for later procedures. When you have a aligned valve, you can think about things like basilica or shortcut more reasonably, because if you would have a commissure in front of a coronary, that wouldn't make too much sense, or that would increase the risk for coronary obstruction with a later procedure. And the plus means that there are big holes for the coronaries. So you align the valve correctly and you leave big holes to re-access the coronaries for later coronary procedures if needed.
So if I understand you correctly, guys, and I like discussing with you because we brought so many important concepts for our younger and low risk patients. First, we need to get a proper valve performance, good hemodynamics. We need to use a device that had a good durability. Sabine, you said keeping the access to the coronary arteries with commissural alignment and potentially the open cell design of the FX Plus. There is, so my question to you, and maybe Danny, you can start with that. Do you systematically try to achieve a good commissural alignment, or sometimes do you accept a kind of trade-off depending on the anatomy of the patient?
It's really amazing, I must say, that only 5 years ago, maybe 6 years ago, no one cared about commissural alignment.
Exactly.
No one cared. And if Sabine now is doing open heart surgery and will put a commissure of the surgical implant in front of the coronary, someone would say this is unacceptable, right? It's not something to be done in surgery. So why should it be done in TAVI, right? There is a coronary ostium and we want a leaflet in front of it. We don't want a commissure in front of it. It doesn't make sense. So I try, especially in younger people, to have good commissural alignment. And usually if it's aligned well to the left main, it will be aligned reasonably well for the RCA, not always, but usually. And I'm not obsessive about it. And if for some reason it doesn't work, then I do not do a lot of work in bringing the valve back and in. But usually it works very well. You just need to put the top hat at the right position with the Evolut. I think this is one of the great advantages of the Evolut platform, is that you can really plan the alignment of the commissures, and we don't have it well in the other devices, at least nowadays.
So we should try to achieve commissural alignment as much as we can. And let me turn to you, Deepak. We have coming from the US was that cusp overlap technique, and there are differences between Europe, Israel, Asia, the US. In terms of the steps of the procedure, particularly the type of guide wire that is utilized. But is it something that you systematically do or would advocate for a younger low risk patient, that cusp overlap technique with that platform, the self-expanding supraannular valve, or is it sometimes something that you don't do? Would it be systematic, and could you describe it?
Yes, sir. And so, great question. We use it systematically. We've become very comfortable with it. In the Optimized Pro trial, we were using Evolutes before the trial, and we didn't use any cusp overlap in that era. When it came out, I think many of us wondered, does this really make a difference? Is it worth learning and modifying our technique, changing wires potentially to using a Lunderquist, for instance, in the beginning? We've now moved away from using Lunderquist, but initially in the trial, we used them the vast majority of the time. So with cusp overlap, it's actually, I'm a huge fan of that technique. We've shifted our whole practice to use it really in every case. If for some reason we can't, the angles are not possible, then certainly there are other good techniques as well, but we think it's so reproducible. And to Danny's earlier point, commissural alignment is so easy now with the steps of flush port alignment and looking at hat markers that these two work very well together. So we roll our camera to LAO. We go up and look at the hat markers as we advance over whichever wire we use, and we use all the major wires at different times. Like I said, for a while, we use Lunderquist more often, and now we've migrated back to wires that have a slightly lower risk of distal edge complications.
But does it have an impact on pacemakers in your experience?
Yes, great question.
Yes.
We've gone up and down, and we're in single-digit pacemaker rates with our Evolutes now, I think really because of that high positioning with cusp alignment. That's such a great question. Yes.
Okay.
And so just to finish out quickly what you said, so then we'll use both RAO and LAO positions to know exactly where we're aligned. And the only real trick I think you have to mentally prepare yourself is when you're in RAO position, you pay attention to the left side of the screen and really don't let yourself pay too much attention to the other side. And then when you flip your LAO position, then you're now focused on the right side of your screen. So you have to differentially look at the two. But to your point, I think it makes a huge difference in pacemaker rates if we follow that properly.
Thank you very much. So I think it's a very important aspect, this pacemaker issue, because there was the publication of the 5 years Evolut low risk randomized trial, and in the presentation there was a deep dive into the pacemaker issue. slightly more, not slightly, more pacemakers over time with the self-expanding platform, TAVI, we're going to say, with a self-expanding platform. But what was reassuring was the lack of impact on the mortality of the patients. And that's really reassuring to me, because it's that was one of the questions. Was it going to impact the lifetime, the survival of the patients? Is it going to induce more pacemaker-induced right heart diseases? It doesn't seem to be the case in this randomized trial. So this is reassuring. We need to wait for the 10 years follow-up, but I have to say that I was positively surprised and impressed by this data. There is one thing that I think it's worth discussing. We know that in small annuli there is a difference in terms of hemodynamics between the self-expanding supraannular platform and the balloon expandable valve. So maybe Sabine, to you, do you think that this is going to translate into a different survival over time, different or quality of life, or even let's say durability of the devices? Do you think that this is going to provide something meaningful in terms of heart clinical impacts? Because you've worked on that, the severe patient prosthesis mismatch in the surgical field. What are your thoughts, perspectives on that?
Exactly. So that's what I wanted to mention. There is a lot of data from surgical aortic valve replacement, and the majority of the studies do demonstrate that especially severe mismatch does impact survival and outcomes. But as mismatch is not the only factor influencing these outcomes, these hard endpoints, it's sometimes difficult to really demonstrate the effect, or the effect size might not be as large as some other factors. But I strongly believe it's a very important factor for outcomes, for left ventricular hypertrophy regression, for even for symptoms. So exercise capacity is reduced in patients with severe mismatch, and some other endpoints also. So as we take so much attention in surgery for this patient prosthesis mismatch, I think this should also be done for TAVI.
Thank you. So we still have a couple of minutes before moving to the next part of the webinar. So this is such an intense discussion. We could require more time, but there are questions coming from the audience, and the first one is about if you could summarize, one of you could summarize the tips and tricks for TAVI with this self-expanding platform in bicuspid valve. Challenging, summarize it. Deepak, you seem to be on track for that.
Yes. So bicuspid valves can be treated very beautifully with this platform and with the TAVI techniques. I think the things you recognize is the sealing skirt will seal at a higher level than with a tri-leaflet valve. And so we always are careful on valve preparation. There tends to be more calcium, and so we always balloon bicuspids before we implant a valve. That allows more uniform expansion. It just makes, I think, the procedure ultimately safer, because you can see how the balloon expands, you test your pacer, and then you're ready to put the valve in. We'll accept a higher level annulus alignment in a bicuspid valve. And I will say our results, I think we went into treating bicuspid patients with more caution, because many of those patients, you have to be careful and assess the size of the root and make sure that surgery is not the best choice for them. But we've been extremely pleased with the results. And as the trial data has shown that to be really the case broadly, I think this is a great technique.
Thank you for this very nice summary. And the other one, there was another question, maybe we can address that after the second case, that was about the risk of coronary obstruction, integration of the risk of coronary obstruction for the choice of the valve at the index procedure. So it's going to be interesting. We're going to keep that, Amir, that is connected online, keep your question for the second part of the webinar. So if I kind of try to summarize that very important and intense discussion that we just had with you guys, what I understand is first the choice of the TAVI, the procedure for AS at the in a younger, low-risk patients is very important, and we should integrate the surgeons for sure, but also the will of the patient, because he's going to be the one that is going to handle all these subsequent procedures and a proper, tailored sequence for him. Second, the choice of the TAVI device, the first TAVI device, is of importance because we want to ensure good hemodynamics, good durability. That's important for lower risk patients, no regurgitation, a very low pacemaker rate, integrating the cusp overlap projection and cusp overlap technique. That is very important. And I like the discussion about commissural alignment, because commissural alignment is going to be something that is going to promote the likelihood of a redo procedure, a TAV in TAV procedure in the future. And so this is a very nice transition to you, Deepak, for the second case. That is going to be a case of a redo procedure, and that is going to be challenging and interesting.
Dr. Cece, thank you so much for the invitation to present this case to this distinguished panel and to this audience. I know we'll be pulling up my slides in a second. And this case is an interesting complement to the previous one that Sabine had shown us. So this is a 69-year-old female referred to our facility with initially New York Heart Association Class 2 dyspnea on exertion and some chest tightness as well. She had previously undergone a TAVR procedure in the past. So in 2017, she had a diagnosis of aortic valve stenosis. She had implanted a 23 millimeter sapien valve. So in the case we just saw, we had the advantage of the modern era knowledge of hemodynamics and of smart data. Back in 2017, we didn't know this. And so at that point, we elected to use a sapien valve. We would probably, frankly, do that differently now based on the fact that this is another case where we're using a 23 and a smaller annulus. This patient had hypertension, hyperlipidemia, sleep apnea, and diabetes. I will mention the original discussions our heart team had in 2017 where we debated between a surgical procedure and a transcatheter procedure. And one of the other things that we see in female patients is oftentimes they have concerns that are a little different than in some of our male patients. She was taking care of a sick husband with cancer. She was a little bit younger than the average patient at that point that we would necessarily send in the direction of TAVI, but we knew from a lifetime management standpoint she would likely get multiple valves. Part of what helped our decision in the direction of TAVI in her case is she was taking care of a sick husband and didn't have the time to recover from a surgery. And so as we discussed, we said, you will be getting a surgery at some point, but our team, our heart surgeons and our interventional cardiologists and imagers were comfortable with the idea of doing TAVI first, with potentially surgery as the second or third procedure to come. So on this representation, when she came back more recently, we diagnosed prosthetic valve failure. She had severe aortic stenosis with a mean gradient of 41 millimeters of mercury, an effective orifice area calculated at 0.6 centimeters squared, and a Vmax of 400 centimeters per second. Her gradient immediately post-implant was 18 millimeters of mercury. Now, I certainly wouldn't be happy with that in this era. Compared to the case we just saw where you have a single-digit gradient, this is a double-digit gradient. But back in 2017, we didn't know everything we know now. She went on to have a standard workup with coronary angiography, which showed no significant disease. Her CTA showed early valve degeneration of that sapien valve with significant calcification in a non-coronary cusp position. Her left main height from the neoannulus was 13.5 millimeters, and the aortic valve annular measurement was 23. Coronary angiography, I'm just showing you her coronary height is reasonable. It's not the highest we've seen, certainly, but her coronaries are clean. And so one of the considerations we had in our mind is the coronaries are a little lower than would be ideal for now thinking about a valve-in-valve position. We talked about surgical versus percutaneous treatments. On CT, what we see again is you can see that on the left side, the VTC is just under 3 millimeters. On the right side, it's nearly 5 millimeters, but that led us again to concerns about what are we going to do with the sapien valve. There obviously in 2017 was no form of alignment, so the valve is where it is, and we have some concern about coronary obstruction on the left. The VTSTJ on that side was about 3 millimeters, as you see. So we talked about options, and after careful heart team consideration and discussion of all options, we had many of the same concerns as before. In this case, a combined decision from our surgical and IC team was to proceed with a valve-in-valve procedure we would be using a TAVI valve, and in this case, we chose an Evolut platform. And we decided that because of the left sinus being narrower, we would perform a balloon-assisted basilica. Since that time, we've developed expertise with the shortcut device. There's the telltale device, and I think as we think about what we're going to be doing in the next decade, we really think coronary modification, which we feel like we're pretty good at right now, will only get better. So in her case, the reason we made this decision in concert was we thought the left main height was low, the VTC was shallow. There was the positioning of the prior prosthesis we had to take into account, and there was a mild degree of commissural misalignment. We were fortunate that it wasn't as much as it could have been, and now, of course, that's why, as we discussed in the last case, we would be focused on making sure we had good coronary alignment. To run through the case, we did this under TEE. We can see there we have an AL catheter. It's an AL3 aiming in the direction that we want to access. You see a snare, a gooseneck snare going into the left ventricle, and a buddy wire. You see the temporary pacing wire, and we are here ready to move on and do our basilica. So here in this view, you can see us approaching with our electrocautery wire, and we pass that wire right through. We tend to use TE as well as fluoroscopy. The fluoroscopy is probably more useful in my mind, but it's nice to be able to see in TE, since it's there anyway, that we look like we're in the right spot, and we can assess aortic insufficiency and make sure we're within the frame. Here I've tried to capture for you the TE images that show good positioning of our catheters, and we're ready to go ahead and perform electrocautery. In this case, you see on the image on the right that a standard basilica procedure creates more of a V-type formation. And in this case, we thought that by doing a balloon-assisted basilica and starting by ballooning over that electrocautery wire and then using our flying V to make a resection, we can create a more U-shaped opening, and that maybe would give us additional perfusion. There's obviously no randomized trials, but in this case, you see on the image playing that there's a 3.0 coronary balloon that we've advanced over our electrocautery wire, and we balloon the vessel. Now what we do next is we make our flying V, and we retract back, and that creates the laceration to complete that. And then from there, we can now see what always amazes me with these basilica procedures is when we first started doing them, I thought we'd see torrential AI, and we don't. It seems like the leaflets fold down in place. So as long as you have your next valve, the new valve you're implanting ready to go, the patients are actually very hemodynamically stable during this procedure. But you can clearly see an increase in the amount of aortic insufficiency on this procedure. The next thing we do is we get ready to implant our valve, and here you see what many of you are very comfortable and familiar with, which is a standard implant of an Evolut valve. And on the right-hand side, you see the valve in place, and then we post-dilated it once again. Here, there's no option for fracturing the sapien, but we can get it expanded fully and make sure we've pushed that calcium to the side. And remember, we started with a gradient at the end of the last case with just the S3 of 18. We had a gradient of 41 as we go into this. And now what we see is a final gradient of 12, which is impressive, right? That's lower than what we ended with on the last procedure. I'd love to get a single-digit gradient, but for having two valves in place, I think this result is very satisfying to us. Angiography post showed no complications, no paravalvular leak. Echo in the room looked good again with no leak, and the patient was discharged in stable fashion on post-op procedure day. Again, young enough that we're in our minds anticipating a potential third valve down the road, and we'll see what technology looks like at that point. But the patient understands that may be a surgical valve at that point. So in this case, the take-home messages were valve-in, valve procedures. We really have to think about the risk of coronary obstruction, and that's why, again, taking that into account on the very first procedure makes sense. We certainly think surgery is a great alternative for many of these patients in the first or subsequent procedures, but we've been very pleased with the results we've gotten with valve-in-valve procedures, and we'll typically use a different valve from the first. Our current practice is we tend to favor, if coronary height is reasonable, to put in a self-expanding valve first, knowing that we'll probably put in a balloon expandable valve on the next pass through. And valve-in-valve really is becoming standard of practice. And as the panel has said before, thinking about coronary access and techniques on leaflet modification really, I think, is current state of the art and is only improving as we go forward. Thank you for the opportunity to present this case.
Thank you once again, a fantastic case that is going to generate a lot of discussion. I guess the very first question goes to you, Sabine. You have the surgical skills, so it could be interesting to learn from you how it is to do an explant, a TAVI explant. Is it something that is difficult, or is it something that is that varies from one device to the other one, or even one patient to the other one? What is your experience on that?
It varies a little bit from one patient to the other. I think the main point here is that as a surgeon, you have to know the stent device, how is it designed, where does it anchor, how does it look like, can it be folded or not, is it a balloon expandable or a self-expandable valve? So you need to know all these details of the prosthetic valve to make a good procedure. I think the patient, this was a great case, Deepak, but your patient is also an operable patient in theory, and I think she would have had a good result also with surgery. And so the nice thing about these TAVI explants is that in patients like yours, it is a first sternotomy or first pericardiotomy procedure, so there is no redo situs inside the chest. So there are no adhesions. It's like a first sternotomy. That makes it quite easy. But of course, to make this discussion complete, we know the results are with increased mortality. It's from 11 up to 18% with 30-day or in hospital mortality for these cohorts. And it is very important that we work on reducing this. And there is, for example, one statement paper from a surgical community with standardized techniques, surgical techniques, how to explant these valves. This is very important, that surgeons are educated and that we standardize techniques to improve these results.
So that's a very important and strong message. We need education, and we need to share knowledge on the surgical techniques to expand the TAVI devices. And maybe something that we could consider, as you said, higher mortality for an explant procedure, but these were high risk or inoperable patients. So maybe that's something that could be different with a younger and lower risk population. So let's come back to your case now, Deepak, and there is so Amir had questions about the risk of coronary obstruction, the overall risk, and he had two questions. Let's start with the second one. The second one is about a different combo. We know that so Evolut is going to have the CE mark, the approval for TAV in TAV. It's pending, and that's a superb thing that is going to bring everything from off-label status to on-label, and that's great for our patients. But Amir was asking if you had started with the first combination as we propose of a self-expanding supraannular platform, given all the benefits that we've discussed with the first case, and assuming that there is a higher risk of sinus sequestration, coronary obstruction for the redo procedure.
I think to Sabine's point earlier, one thing you have to think about is you have to think about the potential surgical benefit of doing a surgery as the second valve in a case like this last one. And we really talked through that very thoroughly. Our surgeons are integral to that decision making. And truthfully, a lot of times I find as a cardiologist, I have a patient who's very eager to consider a TAVI approach, and I have to do the job of convincing them that that's not the right thing, that surgery is the right thing. In this case, I could go into it for a longer time period, but the team decision was that TAVR was a reasonable option in her. And so to your point, and maybe I see we can see you now. Maybe I'll let you finish your question to make sure I stay on track.
The question was if you have, we transition from the first patient with a self-expanding supraannular platform, and now comes the time for a redo procedure. Risk of sinus sequestration. What would be your strategy in terms of coronary protection in this scenario?
That's such a great question. And again, we don't have a lot of random trials as yet to guide us in this, but we know we have a lot of different techniques, from snorkeling stents or putting a stent down at the beginning. If it's a single area we're concerned about, now that can be more complicated with valve-in-valve, but is still possible, and nice results have been obtained. You position a stent either before or at least a wire to protect yourself. Frankly, we've had to do less and less of that as we've gotten more comfortable with basilica, with balloon-assisted basilica, with shortcut, telltale, and other devices that make leaflet modification easier. And so again, as we've said several times, this is my personal belief, but I believe still the focus is get your best first result on your first case, and then the techniques have evolved such that we can usually perform leaflet modification. One or the other, or even both leaflets can be modified to allow us to put the next valve in and achieve what we need to there. I can only imagine what the next 5 to 10 years are going to bring in this as we have data to guide us, but that's my simple answer.
Thank you. Thank you. That's a very clear answer. So let's come back to the very first question from Amir. That was about a scenario into which a patient has a high risk at the index procedure of coronary obstruction. And Amir was proposing a shorter stand frame device. But in your experience, Danny, what is the proportion of a patient? What is the risk of coronary obstruction with a self-expanding platform in a patient with small sinuses in comparison to a balloon expandable platform? How do you weight this risk for both platforms?
So it is very complex to answer that, but I can say in general, it is really surprising to see many of the short TAVI devices, the SAPIEN 3 and also SAPIEN XT that was shorter than SAPIEN 3, to see that they come back degenerated, that they are still at risk for coronary obstruction. We see that more and more, and we can say that patients that are at risk for coronary obstruction, they would be at risk for coronary obstruction with many TAVI devices to be implanted, especially when we want to implant them high. The risk for sinus sequestration is more common, obviously, with supraannular devices, especially when we want to implant these devices. We talked about it at the beginning of the session. We want to implant them very high. We don't want to compromise on conduction defects and on hemodynamics by implanting them 6 or 8 or 10 millimeter in depth. We want them to be healthy, 2, 3, 4 millimeter in depth. And in these situations, especially when the sinus height is not long enough, there could be some added risk for sinus sequestration. I'm very optimistic. I'm very optimistic that in a couple of years we will have a long list of platforms that can enable us to do leaflet modification and to do it easily. Over the wire devices, we have the shortcut device that is FDA approved. It's relatively easy. You did many of these DDA, right? And this is an easy add-on procedure. And I imagine that we do not need to compromise on the first procedure, thinking about the fear of leaflet modification in the future.
That's a very strong statement, and I like it. And I think it opens the door for discussion. You're saying, Danny, so we should not compromise the index procedure, fearing any coronary obstruction in the future. And I think that's a very important statement, because we have to take full advantage of the platforms that we are using. They are meant for certain purposes. We discussed that with you, Deepak, for the self-expanding the Evolut platform, the cusp overlap technique to decrease the rate of PV leak, pacemakers, and we have to think about the immediate outcomes. And this could be a surrogate for an appropriate durability in a dedicated patient. So I like that, Danny, and I think it's certainly something that we're going to discuss more and more in the future before thinking about the redo procedure, because we don't know exactly what is going to be the life expectancy for the patient. If we take, for instance, the Swedish surgical registry, if you take an 80 years old low risk patient, the median survival is like 8 to 10 years. So my question to you, and maybe I can direct it to you, Sabine, is what is for you an acceptable durability of a TAVI platform? Is it 5 years? Is it 8? Is it 10? Do you aim at 15? What do you have in mind? What is realistic? Because this has to be integrated in the decision algorithm for a patient. What is acceptable, to your opinion?
Thank you for this question. I was always convinced that the durability of TAVI prosthesis is equal to surgical bioprosthesis. I never saw a reason why there should be any difference. So I always tell my patients your bioprosthesis, nevertheless, if surgical or TAVI, will last 10 to 15 years. And so I hope this is a realistic estimation for the patient. And that's how I also do the lifetime management discussions with the patient. So if I have a 70-year-old patient, I would say, okay, if your prosthesis lasts 15 years and if you are still living, what are we doing then at the age of 85? So this is how I calculate the durability of a bioprosthesis.
Do you share the same philosophy? Let's start with you, Danny, and then Deepak.
Yeah, maybe Sabine, it will be like that if we talk about biological valves. But if you have a very young patient and you put a mechanical bioprosthesis, then durability will be much different. But unfortunately, people tend not to agree to have Coumadin, and they don't want mechanical valves, right? So the percentage of mechanical valves is only decreasing over the years. It's not coming up.
Deepak?
That's a great point. And I think truthfully now having TAVR options where you can do valve in valve has further pushed us to recognizing that for many patients, there are options. They can get a second valve relatively straightforwardly. So our surgeons, I notice, are using a lot more tissue valves, as you just pointed out, Danny, with the idea that the next valve will be a TAVR valve inside. And that's even easier because they can position the valve so we've got true coronary alignment and think about what other issues exist with the coronaries and so forth. I think, like you both have said, surgical valves and TAVR valves should have, we really should be looking for equivalent durability. And it's interesting looking at some of the early valve data we have from the Evolut platform, which actually shows potentially even better performance than some of our surgical valves, which is what I would hope for, frankly.
Yeah, and I think I like that comment once again. And if I had to answer that question myself, I would say 10 years. I think 10 years is something that is realistic, and that is going to open a lot of perspective for a given patient. Because if you have a device that lasts 10 years, and this was reassuring from the Notion 10 years data, and you can anticipate the need for only one redo procedure or maximum two, but one on average should be the magic number for our patients, for the patients that we are treating so far. Even if they are slightly younger, longer life expectancy, we can aim at one procedure with a device that lasts at least 10 years. That's what we do and what we try to integrate into our decision. So we still have a couple of minutes, so maybe we can come back to some questions from the audience. For you, Deepak, you have your patient, redo procedure. Unfortunately, there is a need for a third procedure. What would be the sequence for that patient, and what type of device would you use?
Yeah, what a really great question. And that's a tough one to easily answer. I think that's going to be a lot of individual patient estimations. We're using in more and more AI platforms in our decision making, and the AI platforms go beyond just looking at VTC and some of the other simple parameters. And I think those platforms are going to really help us make some of these decisions. Valve in valve virtual modeling. Some people use printed structures, but we're using a system called DASI, where we can do some of these projections. So what would be the valve I would use? Again, a focus for me is number one, get the patient in, successfully treat their AS, which means focus on hemodynamics and avoid complications like, for example, pacemaker risk, PVL, and avoid coronary obstruction is probably one of the big ones. Pacemaker risk is going to be very low in a valve, I believe. But coronary obstruction is something we'll have to think about. And you all have very intelligently addressed the issue of coronary leaflet modification that may be possible. Our surgeons are getting better and better, and I think they will be looking at surgical valves in some of those patients that have had 2 TAVI valves before more and more. And that's where the discussion earlier about having consistent surgical techniques is important.
Thank you for that. And there was one question regarding the antiplatelet, or let's say the antithrombotic treatment for these patients, because one can imagine that the flow maybe a little bit disturbed within that scaffolding. So Sabine, do you provide Coumadin to your patients, redo-TAVI patients, or do you go for a single or dual antiplatelet?
So it's as we don't have really guidelines for that, it's an individual decision. So if we think there is an increased risk for some thrombotic events, we would do more than only single platelet.
Thank you. So I have to say that for me, if there is very small sinuses, and that's a kind of cuisine, and I agree with you, Sabine, we don't have any guidelines. Very small sinuses and a risk of thrombus formation, I tend to put the patient under NOAC. But this is empirical. We don't have data. Maybe we need this type of randomized trial in the future. What do you do, Danny, in this type of patients?
Yeah, we don't want to do any harm to our patients, and it's challenging to give medications that can cause harm, that can cause major bleeding, right? If we give them strong anticoagulation, then potentially both people they can hit their head and have a bleed that could be even interesting. We know the truth. Scenarios are known for thrombosis. We see the SMART data we saw in the sapien group in small annuli, relatively higher risk of having valve thrombosis. And I do the same. When I'm concerned about the anatomy, we know that we distort the aortic root when we implant our valves. This is not a natural thing. In diastole, we don't have these big sinuses filled with blood. There is a lot of foreign material in the aortic root. I understand the need for anticoagulation in many of these patients, and I try to balance the risk for bleeding with the potential advantage. So when we have valve-in-valve conditions, especially small valves, and especially patients at risk for coronary abnormal flow, like the beautiful case of Deepak, then I would give anticoagulation for a while.
Thank you very much. So guys, we are coming to the end of this webinar, and it was a very interesting discussion, and I enjoyed it a lot, and I could see that the audience as well, you guys connected online. Together, what we could discuss is the issue of patients with that are young, with a longer life expectancy, and the impact of the choice of the index TAVI device for the very first procedure that is going to impact the likelihood of achieving good hemodynamics on top of low pacemaker rates, no regurgitation, keeping the access to the coronary arteries. And we have contemporary platforms that can achieve that. And a very strong message was, and the choice of a self-expanding supraannular platform makes sense in the vast majority of the patients. And for sure, it has to be tailored to the overall anatomy of the patient, and in some situations, another type of platform may work, and it's fair to state that. We could discuss the challenges of the redo procedure, because these devices, even though they have a great durability, and we've seen the 10 years data from the Notion trial, they're going to fail. And by the time they fail, we have now technical solutions, devices and technical solutions to overcome the risk, to tackle the risk of sinus sequestration and coronary obstruction for our patients. And we could see two very interesting, beautiful cases, nicely executed, that drove a lot of discussion. It's still ongoing. It's going to be burning issues that are going to be addressed in all the meetings that you've seen, the PCR meetings, a lot of valve meetings, and I'm happy that we could continue this discussion face to face. But I would like to thank you all for attending this webinar. Thank you, Sabine, Deepak, Danny, for driving such an intense and very interesting, extremely educational and impactful discussion. Thank you for that. Thank you for sharing your knowledge. Thank you to Medtronic for supporting this webinar, and I hope that you guys online learned a lot. For those who couldn't connect, this webinar is going to be available on demand. So feel free to connect on the PCR website and to look for this webinar. So I wish you all a very nice rest of the day, and hope to see you soon, very soon, face to face very soon. Thank you, guys.
Thank you so much. It was a great pleasure.
Thank you.
Thank you.